Thank you everyone for having us today, and excited to present about some of the work that we have been doing at CHI Health Creighton. So I kind of explain some of our journey that we've been in. I joined as infectious disease physician about 11 years ago. And when I started, we had a lot of CODIs, CLABSIs, and it didn't reflect true infections, but I started seeing we had opportunities. And working with that amazing infection preventionists, we started looking into stewardship. How do we do diagnostic stewardship in order to reduce the numbers of CODIs, CLABSIs in our system? All right. So our talk is going to be on background on multidisciplinary approach for diagnostic stewardship, some of the tools we use for diagnostic stewardship, team approach, as well as some of the results that we have had through diagnostic stewardship. So those are some of our objectives. Here's a really nice paper that was published, which talks about how diagnostic stewardship and partnering with how can we reduce unnecessary testing? Because a lot of times, I'm sure in your healthcare facilities as well, you notice that you have a lot of unnecessary ordering. Some of the experience when we dove into our cases is that a lot of times when a patient is having fevers, our patients get pan culturing. I'm not sure how many of you have seen that. Blood cultures, urine culture, sputum culture, without coming up with step-by-step approach. So we saw a lot of opportunities, and we're like, how do we address this? So this is one of the opportunities, working with laboratories to reduce and make sure we're ordering the right test at the right time. Secondarily, we started having some chatter nationally. If you think about, more than 70% of our hospitals are tracked for HAIs through NHS and CDC. However, the definitions that we are using are surveillance definitions, not true infection definitions. Do patients really have a true infection, or is it contamination or colonization? So how do we work towards better understanding that so we can reduce unnecessary antibiotics in our patients and reduce resistance? So here's an example. You have a patient that comes in, and we order a C. diff test. They're asymptomatic. However, if it's after day 4 and you have a positive C. diff, it's a hospital-acquired C. diff, but they might not have any symptoms. So is it true infection or is it colonization? So how do we reduce false positive testing, unnecessary testing? There's more discussion in 2019 through CDC that we should be using diagnostic stewardship, and it can help in HAIs in the hospital system, and we can reduce SSI, surgical site infection, C. diff, bloodstream infections, folate catheter-related infections, if you're using some of these extra tools that we have. Not only will this have better patient outcome, but it'll also have implications for our healthcare systems. Because every time our healthcare system has a bad outcome, not only are we losing dollars, but it also gets reported and it looks bad on the system as well. So how do we continue this journey? So at CHI Creighton, we started forming a multidisciplinary team. So we are very closely work together with our infection preventionists, infectious disease physicians, as well as our quality leaders. And working together, we have a broader team. We have physician champions, we have EVS champions, IT champions, ICU physicians, physicians from all the different disciplines. We all work together. We have many ad hoc teams as needed, and come up with some tools that we can't use. Some of the tools that we have recently is working really closely with the IT and laboratory services to implement two-step C. diff process, using Kieran device through our laboratory services to reduce blood contamination rates. We'll talk a little bit about that more. But also, when there is an order in the hospital, for example, for blood cultures when a patient has a central line, urine culture when a patient has a folate catheter, C. diff test, those requests come through our infection prevention team. So Angel and Becky, for example, might get an alert there is an order placed, and then we review those cases as well. If needed, we reach out to the provider at bedside to discuss the patient. It's always friendly, it's always teamwork, it's always collaborative, not policing, but building that culture of collaborative work to make sure that order is needed and necessary. At nighttime, we noticed we had increased ordering, especially in the ICU setting. So one of our infectious disease physicians, we take call on patients who have lines that orders are placed to make sure we review at night and work with the team at the bedside to make sure those are appropriate orders as well. And then our infection prevention team, we do a many monitoring, hand hygiene, isolation practices, our initiatives that we are starting, we keep us all in track, we continue to monitor all of those. And as well as every time we have a HAI in our hospital, we have immediate, we get together and we discuss the case and we discuss gaps and we discuss opportunities. So if you have a C. diff, within the next couple of days, we pull the team together, pull their frontline provider, nursing staff, everybody that was involved in that case to look at what opportunities did we have and how can we learn from this, and then continue to build better practices. And we also have really good IT infrastructure, and we are continuing to work on hard stops when needed. For example, for C. diff, if somebody got recently laxative, they have diarrhea, is this due to C. diff or is it laxative related? So there are some hard stops to make sure that providers are stopping and thinking. So there's a lot of IT infrastructure being developed as well with physician champions. And then I'm going to transition to Angel.
Thank you, Dr. V. So we're just going to kind of talk about what we do, either as a division or as an individual hospital to help reduce the incidence of these infections. So CHI Health, we have a system-wide HAI committee, and so we meet monthly, and each hospital presents their cases for the previous month. And we each disclose what our findings were and learnings opportunities, because if one of our campuses has an opportunity, obviously we all want to know so we can apply that to our campuses as well. And then we discuss best practices. On this committee as well is members from our education team, because a lot of our HAI initiatives involve around education. So we want to make sure our nursing educators are involved. We have lab present, pharmacy, because all of those, as Dr. Vivekanandan mentioned, all of those components touch our reduction in HAIs. So we're going to dive into what we have done for our C. diff infections. So this is our journey with HAI C. diff at CUMC Bergen. So as you can see, over the last 4 years, we have had a significant reduction in both the quantity of our cases and in our SIR rate. And it's, again, with all of our HAIs, it's never a one thing that made this happen. It was a bundle approach, multimodal approach. So one of the biggest initiatives, and nurses in the room know that a lot of the initiatives for any of our HAIs kind of falls on our nurses' shoulders. So what we really did was a bedside nurse-driven C. diff initiative where we really empower our bedside nurses to, if that patient presents on admission with diarrhea, or to really monitor them daily for loose stools. One of our opportunities with our most recent cases of HAI C. diffs is our not being able to do early recognition. So these patients presented within the first 3 days of admission with loose stools, but we didn't recognize that until after day 3. So as Dr. V mentioned, after day 3 or more of admission per NHSN guidelines, it's hospital onset C. diff. So we created a tool that I'll talk about in a little bit to help them recognize that, get them placed in isolation immediately so we can decrease the risk of spread and contamination to other patients. And then we've created, we had one C. diff checklist, but now we kind of have 2, but we don't like the word checklist as much either, because as our initial presenter mentioned, that has a bad connotation to it. So we really wanted these to be tools. These are tools to help us drive decisions and collaborate with our providers and everyone else on the team to make a decision what's best for the patient. And then obviously we monitor for isolation compliance, PPE compliance, and that's ever going. And then participating in the HAI review, our nurses are very much involved in that. So our Code D checklist was actually as a result of our cases where we recognized that we had opportunities to see these on admission. So really it's encouraging isolation and testing during the day 1, 2, or 3 of admission, where admit is day 1. This was a struggle, but we really did a lot of work because with nursing, we really were hounding a don't test, question, but then day 1, 2, and 3, we want you to test. So that was kind of a lot of work, and it's still ongoing. But they've really really took that on and really wanted to make sure that they're catching these patients, so that way we're getting them properly isolated and getting them tested and treated if it's appropriate. We also want to be placing a priority on the ordering. So this doesn't allow the nurses to place the order, but it encourages them to have that conversation with the provider of, this patient has diarrhea, Bristol 6, 7 stools, what do you think, should we test, and then go from there. So this is an example of our Code D checklist, and as you can see, it's basically just Bristol 6 or 7, do step 1, 2, and 3. Isolate, make sure that we have a sign that we put up inside our patient rooms over the hand sanitizer to remind everyone leaving to wash your hands with soap and water, not use the hand sanitizer. Make sure that we're getting bleach outside the rooms for cleaning, and then have that conversation with the provider if we should order a GI pathogen panel and C. diff, because obviously loose stools don't always mean C. diff. They could have norovirus or rotavirus, and we want to catch those as well. And this is just a tool we also have for staff and for the providers, just as a decision tree of what's appropriate for C. diff testing that we have on the units. And then this is our checklist we've actually had since 2017, and this is more applicable to after day 3. So this is what we would use after day 3, and this actually goes through the criteria Dr. V was mentioning of, have they had more than 3 loose stools last 24 hours? Are they symptomatic? Have they had laxatives? And help with that decision. Again, the tools are just to help guide, and then if it doesn't seem appropriate, they're to elevate to the provider, and then we can have a conversation. But at the end of the day, the provider's the one making that decision if they feel it's clinically indicated. But then we have this tool, Becky and I asked that they be sent to us, and then when we do our HEI debriefs, we can speak to the team of, they completed the checklist, we had a conversation, it was deemed clinically indicated, and go from there. All right.
All right, so I'm going to move on to one of our next HAIs, which is catheter-associated urinary tract infection, or CAUTI. So here again is our data for where we've come over the last 4 years for our CAUTI prevention, and you can see we had a little bit of a blip there in 21. Was it related to COVID? Possibly, but taking that out of it, we have had a steady decrease over the last 4 years. So very similar to the C. diff checklist, again, going back to we really don't want to refer to it as a checklist, but for lack of better terms, this checklist itself was initiated back around 2017. That was done at CUMC Bergen-Mercy specifically. It was then rolled out to our division, and since then actually has gone nationwide across all of Common Spirit Health, our parent company as well. And the request is that everybody that has a urine culture order, that this checklist be completed, because other places also were finding the same thing we were, that not necessarily all of these tests were clinically indicated. I know this is kind of small, but the top part goes over the symptomology. Does the patient have a fever? Does the patient have gastrovertebral tenderness? What kind of symptoms are they exhibiting? Are they related to urinary tract infection? It also asks nursing or physicians to stop and think, are we testing just because this is cloudy urine, or just because the urine is smelly, or something like that, because those aren't true indications for infection. Then it goes on to just give guidance, do we need to have a conversation with the providers? Do they need to bring infection prevention ID into the whole conversation piece to say, should we move forward? Is there another option if the patient's having a fever? Is there another site that could be causing the fever? But then it also guides nursing. If the test is deemed appropriate by the physician and we go ahead and move forward, it gives guidance to nursing. If that urinary catheter has been in for more than 72 hours, we know we have a buildup of biofilm on that catheter. And so if they're going to pull that off of that catheter, are they getting true what's causing infection, or are they pulling that biofilm off of the catheter? So we do have in our protocol that if the urinary catheter has been in for more than 72 hours, that they exchange it and get the sample from the clean catheter. So this sheet is actually just guiding nursing through that as well. And then again, we ask that it be sent to us because when we review any identified HAI afterwards, we're able to go through and say, okay, we talked to nursing, we talked to the provider, this is what the patient was exhibiting at the time, and sometimes we know when we go back to the EMR, we don't get the full picture. So this is what the patient was exhibiting at the time, this is why the test was ordered. So those checklists are available at the nurse's station for nursing to use. We have also, the three of us, done a lot of talking with our learners. So we have a lot of residents as a teaching hospital, residents, med students, and everything. And we have done a lot of talking with them so that they know this is out there too. So it's kind of a two-sided thing. If nursing sees the order, they get the checklist, they can go to the resident that ordered it and have that conversation. It empowers them to do that. By the same token, if the nurse is calling and saying, hey, I think we might need to test this patient, this is what's going on, the resident can take that checklist and say, well, you know, oh, you want to test for cloudy urine, and that alone is not necessarily an indication to test. So it's kind of a two-way street for them at that point in time. We do ask our brand new learners to talk it over with their attending before they go through with it. And then if there's any questions, we reach back to the provider and say, let us know what's going on, and then you make that final decision. We have a very similar process for our bloodstream, our central line bloodstream infection practices. And here we go again with, we were having some trouble with our CLABSIs, but over the last year and a half, 2 years, by implementing these tools, we have managed to bring it down. And this checklist does mimic very similarly what the CAUTI checklist does. Again, it talks about what kind of symptoms are you having, what are you testing for. Is there any other possible site of infection going on? Because, you know, we don't want to reflex just to immediately testing the blood for a one-time fever if we know that there is possibly they had been in surgery and it was a dirty bowel case or whatever. You know, could we get a CAT scan, or, you know, are they having increased oxygen needs, and do we have a worsening chest x-ray? Could that be the site of infection? That doesn't mean we're not going to do the blood cultures, but do we also need to look into those other avenues as reasons for having the symptoms? This also guides nursing and lab to make sure they collect those cultures, those blood specimens peripherally, not to get them through the central line, which is not best practice, and that they are to use the Curin device so that we have lower chance of contamination. So like the others, this empowers nursing to go back to the provider and have that discussion. It empowers the resident to come to nursing and talk to them. And ultimately, if need be, they pull in one of the infection prevention team or one of the ID doctors and discuss options. And then as a group, a decision is made, okay, here's how we're going to move forward. And then we keep this list so that if this does end up being an HAI, that we can then go forward and say, okay, here's what we saw. So, you know, this talk is kind of about how do we get infection prevention and nursing involved, but we really decided, and Dr. Vivekanandan and Angel alluded to this earlier, that it's really more than just us. It's a whole group of people within the hospital that really affect how we are preventing the spread of disease throughout our hospital, how we're making it safer for our patients. And by having fewer infections, we're treating less with antibiotics. So how are we doing that? So one of our key members, and especially for the C. diff effort, is our housekeeping services. So they currently have a monthly report of ATP testing. So when they have an isolation room that's discharged, They go through and they swab that room after cleaning, and until everything comes back clean, they do not release that room for use for the next patient. That is all kept electronically, and they report that out at all of our HAI meetings and our infection prevention meetings locally as well as at our division. They have a process of using bleach for all isolation room discharges, not just the C. diff ones. They have ongoing education and competency monitoring within the EVS department. EVS people have a special training that they have to clean these rooms. As a nurse, I would not be a good person to go in and clean those rooms. They have a special process they use, and they're watched to follow that. And then they are invited to come to our HAI event reviews so that if they have any input that they can provide that as well.
All right, so our physicians, obviously I mentioned earlier, they're a very big component. We really want a collaborative effort. So a lot of things we've done, and they've been imperative in helping us to do, is our EMR optimizations. So currently we have hard stops in our documentation. So as Dr. V mentioned, if they order a C. diff and this patient's received laxative in the last 48 hours, or they have documented formed stools, the EMR will not allow them to order, and really just prompts them to have a conversation. They're, if they reach out to us, and sometimes there are patients that have had laxatives in the last 48 hours or so, and it is clinically indicated to do a C. diff, we can assist them with bypassing that hard stop. Also, an isolation order is now attached to the C. diff order, so that isolation order is automatically implemented when the C. diff order is placed. So nursing is aware to put that patient in isolation until that test results negative or positive. Our infectious disease faculty, Dr. Vivekanandan and many others, help review orders as needed. We utilize them a lot for our provider-to-provider communication if Becky and I are unable to have those conversations, so that's very helpful. And we have a lot of physician disciplines that are involved. For example, hospital medicine, critical care, and such. And we also invite our providers involved in the care of the patients who have HAIs to come to our debriefs and to help provide their take on the care of that patient. And that's been really wonderful, and we've learned a lot from them as far as what's going on, them and the nurses that come. Because as Becky and I mentioned, the EMR doesn't really reflect exactly what's happening sometimes, so when we have that bedside staff and the providers there during these case reviews, they really open our eyes to what's really happening on the units, and we've discovered a lot of opportunities that we can help make their job easier or help make our patients safer by things that we necessarily aren't privy to just by our rounding and getting into the record. Lab is immensely important in our HAI reductions, and we're really happy to have them much more involved in our case reviews. As Dr. V mentioned, we now have a standardized method for the two-step process for C. diff. We've had that for a couple years, and that really has helped reduce our incidence of colonization that have been called HAIs. They're also very imperative in our blood culture collection. They are our experts. We have nurses that do collect blood cultures in our ED and ICU. So we've really looped in lab as to be the ones that really do that education, provide that actual demonstration of blood culture collection, and then they're really our advocates for using the Curin device. So that way that can assist us in decreasing our contamination. Lab participates in our HAI reviews to give their feedback from their side of it. And then they participate in our new quality. We had the quality initiative with the Curin device was a big one, but our blood culture contamination effort, they've really been spearheaded in that process. I don't know if you
Antimicrobial stewardship team works very closely on our HAI reviews as well. So whenever we have a HAI event, they review all the cases, make sure the antimicrobials were appropriate, did we have opportunity, and also antimicrobial stewardship pharmacists alert all of us on infection prevention side. There's a blood culture that's positive, patient has a central line, should look into this case further. So it's a really good collaborative practice that we have. And they're also part of our post-HAI review cases as well. So some next steps. So some of the things that we struggle with, we are academic medical center, so as you know, we have lots of learners, lots of turnover, not only residents and medical students, but we have other learners as well. So we have realized that teaching is not just not enough step to reduce HAIs. You have to be in front, not only teaching but rounding, explaining, and that's why these tools have really helped to have those dialogues with our learners, so that they're critically thinking as well. Because one of our patterns that we have noticed every July and August, our HAI goes up. So just making sure having these tools have really, really helped us on top of the education component. We are working on some education for our patient and family as well to help with HAI, hand hygiene, continuing being champion in the hospital for our patients. Lots of nursing staff, healthcare workers, as you all know, lots of turnover during this pandemic. So we have struggled a lot with teaching and keeping up to date on our culture and practice. So we're doing a lot of work currently continuing to enforce our culture, practice, best practices, and learn. And we're learning a lot of opportunities as well, but try to reinforce what we have in place. So in summary, I would say diagnostic stewardship can definitely reduce HAIs, as you all see in the data in our own hospital. Having a multidisciplinary approach, having these tools have really helped us reduce our HAI. There might be some struggles, but it has been really helpful for us. Unnecessary antibiotic use has gone down. It really creates a collaborative environment, everybody working together. An increase in patient safety and outcomes, of course. And we have definitely seen the data that we have presented, CAUTI's, CLABSI, C. diff rates in our hospital has gone down. And now we are able to share our best practices across our health system. And like Becky was saying, to our national partners in Common Spirit Health. So we're able to now working the process of building some of these tools in our EMR as well. As you know, checklists, tools that are paper is kind of hard. So now we're working on the process of bringing into the EMR to be able to do this automatically. So that's our future goal. So we will stop there and happy to answer any questions.
Thank you, ladies. We loved hearing from you. It was a really great presentation. You talked about onboarding new learners just a little bit, and I would wonder if you could speak a little more operationally. Is that like a module online?
Yeah.
Is it in person? Is it on the floor? Is it before they hit the floor? We'd love to hear more.
Yeah, I will start with the resident learner, fellow learners, and you all can talk about our nursing learners. For our residents and fellows, medical students, we have dedicated hours that are protected to be able, us three, go in front and teach them our best practices. But also this year, we're gonna also make sure they attest. That's our next step, that they have actually understood what we're talking about, and make sure they have all the tools. But they have dedicated time, that's protected time, that they have to attend to work with us on that process for our resident and fellow learners, but I'm gonna pass it on to nursing.
So for nursing, they have a nursing fellowship that Angel and I have what's supposed to be a half an hour presentation each month, but usually ends up to be at least an hour. So we managed to meet with a select group of nurses at that time to discuss what we can provide to them, what they can provide to us, so that we can all work to keep the patient safer. Something also that Angel and I have been doing recently, in addition to what Dr. Vivekanandan was saying in our meeting when the learners come on board, we've actually been trying to get up to the team rooms a little bit more frequently. And it's amazing to walk into the team rooms where the residents and stuff are sitting and just strike up conversations. And we've had some really excellent conversations with them, just a group of 6 or 7 of them in the team room. And I think a lot of learning, and then they reach out to us afterwards with questions. So that's been really helpful as well.
Thank you. That was perfect.
I think one of the added bonus has always been all of us being available and being able to have those dialogues. And especially having those post-HAI events have been really helpful because it's an educational tool too. Not only are we learning about the patient, but we're real life educating each other and learning. So that's been very helpful as well.
Hi, as a long-term care infection preventionist, how do those investigations that you find that those patients are colonized, how do those kinds of reports get back to a long-term care facility?
Can you give me an example?
Certainly. So if you find someone that is colonized from doing all of your investigation and they're not a hospital-acquired infection, how does that get communicated to
Yes.
a long-term care facility in which they came from? Because it doesn't necessarily say in all the paperwork that this person was found to be colonized.
Yeah, I see what you mean. So like, for example, C. diff spores in more than 50% of patients in long-term care facilities have C. diff part of their stools, some studies say. So if you have C. diff, for example, part of your stool, as long as your stool is formed, you can't really do anything. It's formed, it's not infectious. So unfortunately, that's what it is. But as far as if somebody's actually actively having diarrhea and they're getting discharged from our facility, then of course there's handoff. But usually we don't discharge somebody who's actively having multiple stools. You know, you want to wait until they're formed stools, if that makes sense. But otherwise, also, let's say somebody has CPCRE or really bad MDRO infections, of course, that's communicated on like transition of care to the long-term care facility, you know, depending on what you all are monitoring. If that, does that kind of answer your question?
Long-term care usually just gets a report that this is what they have.
Yeah.
They're colonized or active.
Yeah, and a lot of times, a lot of the bacteria, you're colonized and there's really nothing we can do. But unfortunately, patient is not infectious. It's not causing active infection for the patient.
So, great talk. I'm curious about the physician review role and like overnight calls, the time investment that's required by physicians to monitor and all of these cultures.
Thank you for that question. So I have been personally doing the overnight calls, I would say, for the last 10 years as, in fact, ID. And it's not as often because when I first started, there was a lot of calls, but now the culture's there. When there is a call, I might get maybe once a week a night call, but it's usually very appropriate. And usually it's, when I discuss it with them, I am kind of walking them off the cliff. You know, we have culture, you know, we just did blood culture yesterday. We just have urine culture from 2 days ago. We know it's E. coli infection. I think we'll be okay. And it's a lot of times that being that partner and reassurance has really helped. You know, so it's just always partnering and being there. So it initially was a lot of investment, but now the culture has changed. It's not so burdensome. And my partners, of course, when I'm not able to, they do help me out as well. Yeah.
And I'll say for the non-ICU, they reach out to Becky and I a lot over the week. We're obviously available to them 24/7. But the more that we can get all the providers and the residents and attendings on our page, it usually disseminates out so they can really help take a lot of those overnight questions. And we've also emphasized that some of these cultures aren't emergent overnight, so maybe we can have a discussion when the team's available in the morning.